Thank you for joining us. This is the Teach to Reach conference dialogue ahead of the Teach to Reach conference that will take place 26th to 28th of January. We're going to speak with Sharath Srinavasan from the Africa Voices Foundation in just under 3 minutes, I think. And we'll be speaking with Ian Steed, who will be asking the questions of Sharath. Speak about this quite remarkable experience about how voices in Somalia were heard in the early days of the COVID-19 pandemic. Somebody asked questions about what are your thoughts on coronavirus and got responses from many different places. So we'll be discovering that, talking about that with Sharath and Ian in 2.5 minutes. See you soon. Warm welcome. I'm Rida Sadki from the Geneva Learning Foundation, calling in from Geneva, Switzerland. I'm with two guests for this Teach to Reach conference dialogue, Sharath Srinavasan and Ian Steed. How are you both doing? We're going to discuss today with Sharath. He's the co-founder of Africa Voices, organization that focuses on putting the voices of citizens at the heart of the African continent's transformation. He's going to explain, of course, what that actually means in practice. And Ian Steed will be asking the questions. How are you doing, Ian?
Good evening, Raider, and good evening, everyone. Very well, thank you.
All right. So what I know is we have this quote, "Dear Imaqal listener, your voice is important for the response to COVID-19. What are your thoughts on coronavirus?" Ian, can you tell us, kick off, when and where, who says this, in what context, and what is the story that Sharath is going to share with us? Shall we get started?
Okay. Well, the story starts for me. I was at a meeting about 8 months ago, Sharath was speaking at about this project that the Africa Voices Foundation was carrying out in Somalia, and it rang a bell with me because although it wasn't directly about the work that the Geneva Learning Foundation does, it had a number of similarities, I felt, with what we aspire to do in terms of listening to the voices of people on the front line. And and at the time it was the start of COVID, and Sharath was speaking about how these approaches were relevant as COVID entered Somalia. So that was what inspired me to get in touch with Sharath and ask if he would join us tonight. But maybe that question's better passed to Sharath. So what does it mean your voice matters? How did that come about?
Thanks, Ian, and thanks, Rita. It's great to be with you all, and really delighted to tell you a little bit about the work of Africa's Voices Foundation in the context of the COVID-19 response. So that quote that Rita read out, "Dear Imaqal listener, your voice is very important. Tell us what your thoughts are on COVID-19." That was asked to about 50,000 Somalis over text message in early April 2020. And the situation, the context was that they were people who had already engaged with a multimedia interactive radio show over many months that was running on gender equality and social inclusion, and was working with about 30 radio stations across South Central Somalia and Puntland, and putting out broadcasts every week. But what was really interesting about these broadcasts is that the stories, the content was being driven by the voices of citizens. So they were being asked for their views, and Africa's Voices has developed a methodology, a mixed methodology for gathering large volumes of SMS data from people expressing their voice in open text, and bringing that into themes and content that then is used in the production of important social governance behavioral programming. And so there was already this audience, and when the COVID-19 pandemic was emerging, we knew we had a wide-ranging audience that could tell us something that was being missed potentially by the response in those early days. And that response had two aspects which were extreme in the Somalia case. And the first is that, of course, it was a biomedical response primarily, but everything we'd learned from the Ebola outbreak a few years ago was that the sociocultural experience of a pandemic or an epidemic is extremely important to how interventions are received and understood by a community, and also their own risk behavior. And the second thing is, in the Somalia case, it's even more extreme because most of the actors are, because of the insecurity in the country, they're constrained to a physical reality that's the airport of Mogadishu, the capital of the country. So their understanding of what's happening out there in the country and amongst communities is quite constrained. So using radio to reach populations, Africa's Voices programming reaches about 1 million Somalis every week with this radio show, but then hears from a smaller number. And asking for their view about COVID-19 seemed a really important corrective to the discussions that were going on amongst a primarily biomedical community about the interventions that were required at that point. So what we were able to do was consult widely. We heard from about 7,700 Somalis sending their views on that early point of the response, 18,000 text messages that came in, all in Somali, open text format. And we were able to conduct a thematic and then statistical analysis of what themes were emerging, how they varied between different groups, and what kinds of things, implications that had for the kind of response. And I can tell you a little bit more about that as we go into it.
Wow. So to summarize that, you were moving radio from being something that was broadcasting out to being a two-way process that was also encouraging people to share back their views. And presumably, I mean, as you described, that's not something that happens overnight. That's something that's built on trust and long-term relationships.
Absolutely. And I think that's the one thing that we knew we had right at the beginning. So we have an engaged audience that trusts and is actively interested in the content of these radio shows. You can't really switch communications on and off. I think humans are very alert and very aware of when someone's pushing a message in their face, or when someone's not really listening on the other end, or when someone thinks that they know what's best for them and is not really listening to their concerns. So a trusted space of communication is always crucially important. I think the other piece that was a precursor was that Africa's Voices methodology around using interactive radio has been developed over quite a long time. And so it had been really thought through about how to do this. If you're going to open up the airwaves to the voices of the audience, doing that through SMS has all these different things that you need to think about to get it right. And that's been a long-term collaboration out of research that started in Cambridge University, but the organization is very much now based in East Africa. But I think those two things, suddenly we thought we're ready to do this. And we've actually been thinking about this kind of response, what's talked about as the risk communication and community engagement pillar of the response, is something that we had been already thinking about even prior to the pandemic.
Okay. Can you tell us a little bit about what sort of data you were getting back from people? What did the raw messages show, first of all?
Yeah, absolutely. I mean, the first thing, I guess every context is different. In the Somali context, people do express themselves very richly and fluently in text. Now, you obviously got a self-selecting sample as such here. So you're not trying to do a population-based analysis. What you're trying to look at is what are some of the dominant ideas and shared beliefs that are coming out once you look at thematically at the sorts of messages that come out. Now, a lot of those messages were striking, actually, because in that very early stage of the coronavirus, most of the messages, the predominant theme that we identified was a religious theme, that actually people were seeing this through a religious lens. They weren't focusing specifically on the virus itself, but rather as a threat, as a risk, as something that was unknown and uncertain, and that actually, trust in God and fidelity to being a good practice of religion well, and also that this was sort of a slightly fatalistic idea that this is God's decision as to how I will fare and what will occur to me, and those of us who are more devout will be, in a sense, more safe. Now, that was a religious frame that was very dominant, that came out a lot of messages. And at the sharp end of that frame was something a little bit more negative. There was a sort of a negative stigma, which is that this is really a disease of outsiders, of non-believers, and we should be really distrustful of them, and really they should not be in our country. Or this won't happen to us because it only happens to non-believers. And I think that was the sharp end of that frame, and it pointed to some really interesting concerns that needed to be taken into account in the intervention response from the outset. So yeah, that was one side, but there was another very strong side, a frame that was nearly equally as preponderant, a theme, and that was to do the right thing, a call for right practice, and the idea that we have to listen to authorities and health experts, and we should be, following what they're saying. And there was a tendency for that to skew to slightly younger populations that were the respondents that we were hearing from, whereas the negative stigma or the fear or the slight misinformation about the virus, that tended to be amongst respondents more likely to come from those who are displaced. From displaced communities or in more insecure parts of the country as well. So one of our analyses was that if you're in a sort of high risk environment already or an insecure environment, your trust in information is already at a low. And so it tends to be the sort of rumor mill and the anxiety that go with different communications you're getting from different sources tends to be a bigger concern.
Wow, that's really quite, that's really quite detailed in what you're coming back with that. How was that information used? What then happened in terms of the public health response?
Yeah, so it had two primary directions of implications. The first was to other stakeholders in the intervention, so the risk communication, community engagement pillar task force in Somalia, co-run out of OCHA and WHO, UNICEF. There was an audience that was very interested to see what we came up with from this research. Now, we were, of course, part of other research as well going alongside, so it's triangulating with other sources. But it was the clear pivot that occurred there was that in the context of Ramadan, which was also at that time, it would be very important to much more engage religious authorities around messaging, around the response, because it was quite clear that until that time, largely the dominant voices were from the biomedical community as such, right? And then also some of the messaging that was coming from whatever was being templated from, in effect, the global north, because they had seen the virus first. So a lot of this was obviously around hygiene, washing hands, etc., and this sort of individual behavioral messaging. What was coming out for us was that who do people turn to? Who do they trust when they're listening to advice? And actually, they're listening to the sheikh, the religious leader especially, and other local authorities. And so engaging with them on this is very important. And in the context of Ramadan, where there was a clampdown on gatherings in public spaces and indeed in religious institutions, there was a real risk that there was an antagonism between two important sources of authority here, and that would undermine the messaging and thus undermine the response. The second side of this, I should add, was that this was really informative in the programming of Africa's Voices and others who were using media to do broadcasting as well. So it fed a kind of formative research into the design of content thereafter. And so for the rest of the year, Africa's Voices did radio programming again, about 1 million people listening to these shows and 30 radio stations, and programming on COVID-19 issues throughout the year, continuing the loop of hearing and listening to communities, seeing what's on their minds and folding that into the content that was being produced week to week on these themes.
Fantastic. So, I mean, in light of the audience of the people that we're speaking to, these are immunization professionals, often working at the national or subnational level. And many of whom do work with community radio. What would be your advice to these professionals based on your learning in Somalia? What could they take away as perhaps they start to communicate around a COVID-19 vaccine?
Yeah. So when we presented our work back in April last year, I think we ended by saying, the crucial thing is to listen again, and then act. But actually that, this crucial step of listening and kind of listening twice, because we tend to listen in slightly perfunctory ways, is crucial, because the ways in which an intervention can be tailored and nuanced, and that communications can enhance its effect, is so central. And in the immunization community, this is very well known, I think, as well. And we've done some work on polio immunization with UNICEF Somalia some years back, and it was really clear that this insight of listening, understanding what anxieties are there, what kinds of worldviews are there that are going to affect how this intervention is experienced, is crucial. And then that gives, I think, an opportunity to think about how trusted communications need to be configured in particular cultural and social contexts. And they're all different one to the next. And so my sense was that, collaborations between, biomedical communications, health communications people, but also contextual researchers to do this work is so crucial, and can be really the crucial ingredients that can allow for success. So that's one aspect. I think the other aspect is more practically with radio, etc. So the kind of methodology that Africa's Voices involved, I'm sure that the team would be really eager to collaborate with others involved in the immunization drive. But that methodology, there are lighter touch versions of it that can be employed by others, even without the tools, etc., that have been developed by Africa's Voices to handle this. And I think that's a real opportunity, and be very happy for people to get in touch to be given some guidance on lighter touch approaches to interactive radio as a method. It's not easy. It sort of relies on media houses and presenters, and all these things can often go different to how people expect or want it to. But I think some smart thinking around choosing the right media houses, the right time of day, the right presenters goes a long way. And then trying to ensure that it's not shock value or entertainment value that they're focusing on, but also understanding that that's what radio is a bit, allowing voices to come in and then using that effectively. We developed some toolkits on how to use interactive radio effectively as well, and that could be useful. Last thing, I think, was one of the things we did after the radio shows or alongside them is we worked with other researchers and other practitioners to find smaller cohorts within the audience group that were, for example, displaced persons in settlements around Mogadishu, and have a conversation with them over months over SMS, interacting just one-to-one, but with a cohort. We called it a cohort. And we looked at their experience of the pandemic over a period of months, just by exchanging with them in a very open conversational way, not a formal research process way, but we developed a tool called Kati Kati, which allows us to handle those conversations over SMS, but also conduct our research as well alongside to see what themes are coming out. And so we've been able to use the crisis as an opportunity to develop some tools that others have found really valuable to allow them to remote engage with populations or communities over time that are really suited to these contexts. They're not just using WhatsApp or something that is available in another context and just trying to apply it into a situation where it doesn't work as well, but is much more tailored to the context where SMS, for example, is a much better channel of communication.
Fantastic, Sharath. And what we will be doing is sharing these links through the Facebook channel, so people who are listening, who've listened to this and are thinking, yes, I'd like to explore this further, have access to them. I think just a wonderful way to sum up what you've said and to bring this session to an end. I love that phrase, listen again, and then act. And I think that's a wonderful summary. So Sharath, thank you from a cold and wet and windy Cambridge for joining us this evening. It's been great to see you, and thank you very much for your time.
Thanks, Ian. Thanks, Radio. It's been a pleasure.
Thank you both. All right. If you're not at Teach to Reach, this is actually where you need and want to be. If you enjoyed this dialogue from January 26th to 28th, thousands of immunization staff from dozens of countries will be coming together for this conference, for this unique conference. Learning innovation is a key theme as we face the ultimate Teach to Reach challenge of COVID-19 vaccine introduction. Do join us. You can find out more on the Geneva Learning Foundation's website, learning.foundation. Thank you for having joined us, and see you soon.